Chris Wallis. I'm here at ASCO GU 2024. I'm really pleased to be joined by Dr. Brad McGregor. Thanks so much for joining us.
No, thanks for having me.
So we're here to pick your mind a little bit about the data we're seeing. And this morning we saw really interesting results from Dr. Agarwal, and maybe our first data suggesting that there might be a smidge of a role for IO therapy in prostate cancer. So maybe walk us through how we got here, the background, the graveyard maybe of IO trials in prostate, and maybe how this one's different.
Yeah, I mean, as you point out, there's been so many trials with IO and prostate cancer, looking at IO plus versus whatever the standard is, and we really haven't seen much of any improvements overall, like addition of pembrolizumab to enzalutamide or docetaxel hasn't done much. But then we had this really interesting data from COSMIC-021, really this where they looked at the combination of cabozantinib with atezolizumab in a variety of tumors to include prostate cancer. And we saw, this signal of this really impressive response rate, specifically, in those patients that had the worst prognosis. So, the neurologist showed us pictures of this patient had liver mets, and he's on cabo-atezo, and he's on this forever. And so there's this hope that, this really could be a potential marker. It's given some of the concerns of cabo and changing the bone environment and false changes in bone scans. The idea was, can we really offer something novel for these patients that have the worst prognosis? So that was really the basis behind CONTACT, right?
And it's interesting because it's using two different drugs, or two different, maybe even drug categories that we don't use. Normally we're used to using a backbone of something we believe really works in a disease space, and maybe supplementing, and we've got both a TKI and IO, neither of which are really established in the prostate space, and yet we saw pretty impressive results.
Take two negatives, make a positive. Exactly. That was the idea, right? So they took the patients, they took these sickest patients, and so to go on the trial, patients had progressed on one NHT. They could have had docetaxel in the hormone sensitive space, but no chemotherapy in the castrate-resistant setting. And then they had either extrapelvic nodal metastases or visceral metastases. So these were not just patients with bone-only disease or pelvic nodes. These were sort of patients that we know sort of have a poor prognosis. And patients were randomized to get cabozantinib, a dose of 40 milligrams daily with atezolizumab, or alternative NHT. So patients that progress on one NHT would then switch to a different NHT.
Right. And our primary endpoint here is radiographic driven.
Correct.
And positive.
Correct.
So tell me what you make of the sort of magnitude of benefit we're seeing here.
It's a statistically significant study, right? So we had an improvement in the progression-free survival for cabo-atezo versus continuing alternative NHT. That absolute benefit is on the order of a couple months, although that hazard rPFS was highly statistically significant. And with early analysis, OS data remains immature, but there's a trend towards OS, hazard ratio less than 0.8, though it certainly crosses 1 at this point in time. So early on, I think it's really remarkable. Again, we have a positive trial with immunotherapy in prostate cancer. Toxicity profile, nothing that we wouldn't expect from the combination of cabozantinib with atezolizumab based on our experience using TKI and IO in kidney cancer, where we use it all the time. So certainly it had issues, but manageable. And they looked at some of the quality of life analysis, and there wasn't any increase in deterioration of quality of life with cabo-atezo versus the control arm. So from a patient standpoint, we hope that it was well tolerated.
Right. And the question, it was the first question up when the presentation's over. I feel like it comes up every time we're in these disease space questions is what do we make of the control arm? So Kim Chi's data would say that especially if you're doing an Enza to Abi, it's not much. If you're going Abi to Enza, maybe it's got some value. So what do we make of this? Clearly, the FDA says it's good enough.
Right.
But when we're going to clinical practice, is this data strong enough to convince you to take this approach as compared to offering docetaxel as a next line of therapy?
Yeah, control arms in this situation are so challenging, right? It's sort of like, what do you want to do here? And I think from a trial design standpoint, you want to be a purist, right? You want to have sort of the same across the board. So if you did like a dealer's choice, where you maybe allowed chemotherapy or alternate NHT, then you're going to get pretty messy. And how do you do the statistics overall? I think as Niraj pointed out, from a pure standpoint, we actually don't have any data that NHT switch is any worse than docetaxel, although I think everyone has this sort of bias that maybe docetaxel makes a difference. And this is an international trial, and NHT switch is quite popular. Patients are chemophobic, for lack of a better term. So I think at the end of the day, yes, the control arm is always going to have these limitations. And I feel like every meeting we have a discussion about this exact same point. But I think this is a control arm that has been approved by the FDA in the past. Right. So I think it's a reasonable control arm to look at. I think the question we have to ask ourselves is this magnitude, how does this magnitude of clinical benefit, what's that going to mean for the patient we see in the clinic? And I think that's going to be an ongoing discussion. I think, longer follow-up, maybe a little more detail. Are there biomarkers? They did some subset analysis of maybe those who had prior docetaxel did better and different things. So is there even a signal where we can find those right patients? But I mean, we have a limited number of tools to use in castration-resistant prostate cancer, right? And so this offers hope that we may have more in the future. And I think really could be commended for taking initiative, doing this trial, looking at sort of a novel approach. And I think we'll really need to look at the data further and sort of think we look at it as physicians, but we also probably need to talk with patient advocacy groups and patients. What does this data mean to you, right? Absolutely. So is there something there? And ultimately, I think longer term follow-up, is there going to be a tail to that curve with that? I think there's a lot more we can still learn from this, Absolutely. But early signals, I think exciting day.
I think all of us want more mechanism of action, right? The more options you have with different mechanisms of action that offers promise to our patients, and that comes back to our control arm conversation a little bit, right? The more options you have to switch the way we're targeting the tumor, probably the better our armamentarium is. So
correct.